Good morning, good afternoon. It's a pleasure to be with you today with another great webinar. Today we will have a webinar on a fantastic topic, which is touching the gynecologist for our entire profession, which is osteoporosis. And we will have two speakers. One is Professor Antonio Cano, and the other is Professor Martin Birkhauser. I will present Professor Cano, and then I will present later on Professor Birkhauser. As you know, Antonio Cano is professor of technical gynecology at the University of Valencia in Spain. He's chairman of the OBGYN department and Hospital Clínico Universitario and head on the Women's Health department at the Research Institute in Cleveland. He have many merits. He has published a lot of papers, but I want to remember that he have a doctorate as a scholar at the Royal Spanish College in University of Bologna. Then we have the joy also to have during his studying time Antonio Cano in Italy with us. And they have done a postdoctoral fellow of the British Council in the Imperial Cancer Research Fund in London. Antonio was also president of the European Menopause Society. He's now member of the board of the International Society of Gynecology and Endocrinology. And he will speak about the sequential management of postmenopausal osteoporosis. Antonio, you have the microphone. We will all enjoy your presentation.
Thank you, Professor Genazzani, for the introduction and for inviting me to the society, also for inviting me to participate in this webinar, in which I want to show the great pleasure to be here with Professor Genazzani and Professor Birkhauser, both very good friends from several years. The topic I will address is the sequential management of osteoporosis. This is my disclosure. And I will start just by reminding that osteoporosis is a very important non-communicable disease because it extends to a huge layers of population along the world, and particularly women, because they suffer menopause, and osteoporosis is an endocrinological disease. You see in this slide here on the right, cells, osteoblast and osteoclast, which show in immunocytochemistry positivity for estrogen receptors. And on the left, you see here, this is a histological section of the bone in which there are osteoblasts over here, and also the osteoclast, which are multinuclear cells involved in the resorption of bone. So that when estrogens decline, there is an increase in the activity of osteoclast, which lead to an increase in the bone turnover, leading to the net loss of bone, because osteoblasts increase their activity, but much less than osteoclasts. So that disbalance is at the root of postmenopausal osteoporosis. And I have included this title between Scylla and Charybdis because it is interesting to stress that women, some of them even when they are just postmenopausal in the 50, 54, 59, 55, 59 years, some of them are already with a bone mass which is below the fracture threshold. And this is a problem, particular problem, because as you see here on the right, there is an influence of age. This is data from a study in Sweden in which you see that for a certain T-score for BMD, here, for example, think of -2, depending on the age of the lady, the increase of fracture may be higher. So this is important because for those young women that I was commenting, which are already below the threshold of fracture, the time ahead will be one in which they will have to be subjected to osteoporosis treatment. And this is important to know because we need to address an approach in which different strategies need to be followed. Also, just to remind you also that there are differences in the incidence of the type of fractures. Here on the left, you have the incidence of vertebral fractures. You see that depending on age, for women between 35 till 60, 69 years, you see here that around 60, 69 years, there is a very high level, some 300 people per 100,000 years. which is much higher than what one finds for hip fracture, which has an increase in the prevalence at older age, some 10, 15 years later. So depending on the type of fracture, depending on the age, and also depending on the level of exposure to estrogens, the risk for osteoporotic fracture is changing. And for that, we have different tools at hand. We have obviously the menopausal hormone therapy that we will comment. There are other antiresorptives which are using also the estrogen receptor pathway, for example, the SERMs, but also others like bisphosphonates and denosumab. And more recently, we are having anabolics. Obviously, we also have to keep the lifestyle and hygiene in terms of nutrition, physical activity, prevention of falls, and omission of toxic habits, for example, tobacco, alcohol, and so on. And we need to establish an order, a rational approach, what to use and when. I will start just by showing the importance of keeping a healthy lifestyle. Lifestyle, as I was commenting, is not only physical activity, also nutrition, and also other measures. But just to show you how important is, for example, physical activity, you see here on the left, and meta-analysis in which you see that for fracture, the overall value is around 50% decrease for people who practice exercise. And here on the right, you have what is the impact for hip fracture or for any fracture with slow levels of physical activity. For example, you see here, this is data from Sweden again, in which you see that just 20 minutes a day walking and bicycle might impose a reduction of 20% in the risk of hip fracture or any other fracture. So this is important to bear in mind when considering other options, which are in the area of the pharmacological approach, but which is something that should be considered in addition to health lifestyle activity. Then we have the approach of the activation of estrogen receptors. And for that, obviously, we have the menopausal hormone therapy. We have two sources of information here on the left. We have a meta-analysis in which you will find that for total fractures, the balance, the final, the overall result is a 25% reduction for women treated with menopausal hormone therapy. And here on the right, you have the Endocrine Society document, a guideline in which you see that menopausal hormone therapy that you have in here is plus or minus as strong, in this case for non-vertebral fracture, as it is, for example, bisphosphonates. So this is always a good news for women who have to follow menopausal hormone therapy because they are symptomatic and because they want to prevent osteoporosis. And the good news with this option is that the follow-up of women who were treated with hormones or with placebo in the WHI, in the years following here up to 5 years, you see here 1, 2, 3, 4, 5 years, there is a similar incidence of fracture. That means that when these women who were treated with menopausal hormone therapy during the WHI, they did not suffer an increase in fractures as compared with placebo. That means that the benefit that these women acquire by following menopausal hormone therapy is something, a capital that will keep for many years for the rest of their lives. So this is an important news when considering the use of menopausal hormone therapy. But there are other options that also use the estrogen receptor to control bone loss. And one of them is the SERMs, the selective estrogen receptor modulators. And what I have you is data from the use of raloxifene in the MORE study, in which it was found that women treated with raloxifene, you have here the two different dosages that were used in comparison with placebo, and there was a reduction of around, you see here, 0.6, the relative risk. That means 40% or 50% reduction in vertebral fractures. And this is important because you see that despite this benefit in vertebral fractures, there was no benefit in other areas of the body, for example, hip fracture or non-vertebral fracture, despite a slight increase, as you see here, in the bone mineral density at the hip. So finally, fractures were only prevented for vertebral fractures, something which probably helps to allocate the use of SERMs in that interval age of 60, 69, which is the time, which is the age in which there is a very high level of vertebral fractures. Anyway, this is something that we will discuss at the end of my presentation. Also to bear in mind that raloxifene has some safety issues. One is the increase in deep venous thrombosis, in which you see that there is an increase for those women treated with raloxifene, as we know that happens with women that are treated with menopausal hormone therapy. But instead, there is a reduction in the incidence of breast cancer. You see here that there is a reduction in women treated with raloxifene versus those treated with placebo, which is this continuous line that is in this slide. So two different approaches using the estrogen receptor and some more approaches. One of them is the world of the bisphosphonate, in which the action of the is to lead osteoclast to apoptosis. Here in this slide, bisphosphonates go to the bone because they have a high affinity for calcium. They stay there, and when they are swallowed by the osteoclast is conducted directly to apoptosis. This is the mechanism of action of bisphosphonates, which was very impacting. This is the data shown for the FIT study with alendronate, in which the reduction in the clinical vertebral fracture is more than 50%. It's actually a 55% you have here, the difference between women treated with alendronate versus those treated with placebo. And the good thing, which is with this higher control of the bone turnover, is that the reduction in fracture also applied to other territories, like for example, hip fracture, in which you see that there is around a 50% reduction of hip fracture with alendronate, and also wrist fracture. So we have here a stronger product, something that reduces the bone turnover in a higher level than SERMs or menopausal hormone therapy. I say SERMs in plural because in addition to raloxifene, there was another product, basedoxifene, but I haven't brought you the data because they are very, very similar to what I have shown you for raloxifene. So we have here, going back to alendronate and bisphosphonates, good products, strong products that instead also had some problems. One was that the concept of frozen bone. The reduction of bone turnover was that high that some problems arose at the level of the teeth, for example, here, the sternocrosis of the jaw and teeth and the jaw itself, which was very infrequent but was reported in some patients. And also here, the atypical femoral fractures that you see here, for example, the age-adjusted relative risk here, which was almost 50 times more frequent in those people ever using bisphosphonates as compared that the reference, which was people that never used the bisphosphonates. They were very infrequent, but that moved some agencies, like for example the FDA and also the European Medicine Agency, to issue some warnings against the use of these products for more than 5 years. I should stress that it was very infrequent. For example, this is something which I think is very eloquent, in which you see here 10 years probability for a fracture in a lady who is 80 years untreated versus that treated with bisphosphonates, which is certainly, even including the atypical femoral fracture, there is a very huge difference. And also, interestingly, you see here the osteonecrosis of the jaw and also as a comparison, the possibility or the risk of having a fatal motor vehicle accident, which is, or murder, which is in the same area. This is just to put you in the correct perspective concerning which is the actual absolute risk of having these problems. But the thing is that the weakness of bisphosphonates didn't come from this area of the adverse effects, but from the area of adherence. You see here that this is data of the real world, in which you see that, for example, for alendronate, after 2 years of the prescription, less than 50% of the users were still using alendronate. So that finally, the conclusion is that we have a very good product, but if people don't take it, probably we will have a therapeutic failure. Anyway, research went on and other areas were explored, and there is the option of biological products. Here you see the denosumab, which is an antibody against rank ligand. The rank ligand you see here on the left is the cytokine. You have here this sort of coffee grains you see here, which are released by osteoblasts and have the membrane receptors at the progenitors of the osteoclast, so that they differentiate into osteoclasts when they receive a rank ligand. So the idea is that only an IgG, an antibody against rank ligand, decreases the flow of those cytokines into the osteoclast progenitors, and there is no osteoclasts anymore. How strong was this product? It was quite strong, actually. You have here data of BMD as in comparison with 2-bisphosphonates, zoledronic acid in green, or in orange alendronate, and you see in blue the effect of denosumab, which in years 5, 6, even up to 10 years, there was still an increase in bone mineral density. So I would say, one could say that it is a fantastic product, and actually it was reflected in the protection against fracture. You see here, for example, new vertebral fracture or the time to hip fracture, in which you see that the reduction was even higher than for bisphosphonate. We are speaking of 40 or even 20% residual risk. I mean, an 80% reduction of vertebral fracture for those women. This is the Freedom study, in which the placebo was compared with denosumab, and the impact at the level of fracture, both vertebral and hip fracture, was enormous. But again, no product is perfect, and the follow-up of women who were treated with denosumab for a number of years came out to be a state in which there was an increase in the risk of vertebral fractures, and particularly multiple vertebral fractures. You see here in this study, in which women treated with denosumab were divided into those treated for less or equal to 3 years or more than 3 years, and there was an increase clearer in the case of multiple vertebral fractures for those women who had been treated for long with denosumab. So this commits to the need to take some measures in the case of those women who are treated with denosumab. So as a summary of what we have told about anti-resortives, we have obviously menopausal hormone therapy, but in addition to that, we have SERMs using the pathway of the estrogen receptors, and then those with higher anti-resortive potential, in which we have bisphosphonates and denosumab. And you have here the main features. SERMs are a good option in younger women, 60, 70 years, in which there is a high prevalence of vertebral fractures. Also very interesting for women with high risk breast cancer and low risk of deep venous thrombosis. Obviously, if we are thinking of an obese woman, probably this is not the best product. And there is no detected risk related with frozen bone, what we were commenting, osteonecrosis of the jaw and atypical femoral fractures, probably because the reduction of bone turnover was not as drastic for those higher anti-resortive potential products. as bisphosphonates or denosumab, which we have commented in the previous slides. So the panorama was that until a few years in which there was a new area which was open, and it was that of the anabolics, the new paradigm. Until this moment, only actions against osteoclasts were at hand, either the pathway of estrogen receptors, either the apoptosis of osteoclasts, as it is the case of bisphosphonates, or antibodies against the cytokine involved in the differentiation of the osteoclasts. But new products appeared in the market which were active on osteoblasts, and therefore they were increasing bone formation. The two first of them, the teriparatide and abaloparatide, are related with the PTH, the parathyroid hormone, though both are synthetic peptides coming from the N-terminal fragment, 134 amino acids of PTH in the first case, or PTH-related peptide in the second case. And then another biological product, romosozumab, which is again a monoclonal antibody, but in this case against sclerostin. Sclerostin is a molecule which is inhibiting the WNT pathway, which was discovered just 25 years ago. It was discovered that it was involved in the induction of the activity of osteoclasts. So by producing an antibody against the inhibitor of WNT, osteoblasts were supposed to be stimulated, and supposedly there would be an increase in the synthesis of new bone. And I will just show you two studies. Firstly, because one of the regimes that have been proposed for the use of anabolics is to use them in the first place and then an antiresorptive. And this is so because this is the data of one study, in the data sheet study. You have here on the left the design of that study. There were 3 groups of osteoporotic women who were treated, one of the groups with teriparatide first, and then antiresorptive denosumab. The second, just the opposite, first denosumab and then teriparatide, and the third with a combination of both denosumab and teriparatide. And you have here, which is the impact at the level of the bone mineral density, at the level of the spine, and at the level of the femoral neck. And you see that in all cases, the higher increases were achieved with the combination or with the teriparatide first, followed by denosumab. So it seems that for any reason, the initiation with an antiresorptive and then one anabolic probably is not the best of the combinations. And following these indications, I will show you, this is the data I will show you with for anabolics, the study in which romosozumab, the antibody against sclerostin, was used against placebo in a study which had the design that you have here on the left. There was 1 year in which there was a double-blind period in which half of the women were receiving a placebo subcutaneously, while the other half were receiving subcutaneously romosozumab. And after those 12 months, there was an open label period in which both groups were treated with denosumab. The good thing of this design is that in the first year, by comparing with placebo, one may have an indication of which is the power of romosozumab alone as compared with placebo. And you see here that in terms of new vertebral fracture, the reduction is higher than 70% in vertebral fractures. And the good thing later is that by adding denosumab, which is the sequence that was recommended in the previous study that we were analyzing related with teriparatide, the difference persisted and persisted even if the comparative group was receiving denosumab. So even with the improvement by denosumab, the addition of denosumab to romosozumab in the previous year was followed by this by the same difference that was maintained in the second year. So this is excellent news, but is at the same time something that raises questions about how to manage all this armamentarium when dealing with osteoporosis. And that's why the title of my talk was a rational sequence regarding that. And this is something that we published just last year in a group of colleagues in Spain about which might be a recommendation. Obviously, I should say that there is no established evidence that absolutely support this proposal, but this is a certain rationale for establishing an order in all the possibilities that we have to manage osteoporosis. You see here that starting at menopause, 0 time, and then up to 35 years later, we have healthy lifestyle in all the stages. Then we have menopause hormone therapy and SERMs, which are related with activation of the estrogen receptors. Firstly, menopausal hormone therapy, which also has an effect at the level of the symptomatology of those early postmenopausal women. SERMs might be an option later because they protect against vertebral fracture and has nothing to do with hip fractures, which are highly prevalent at older ages. And then we have the traditional antiresorptives followed by anabolics. But as I say, you see here that the anabolics also may have probably an area, maybe an indication in those younger women. Remember that I started my talk speaking of those young women who are above the threshold of fracture. So probably we have an area for anabolics in there. And this is something that we gynecologists are not so used to have these products, and it's something that probably we should bear in mind and we should incorporate into our therapeutical armamentarium. And this might be a little bit some corollarium of what I have been commenting. Firstly, obviously, lifestyle must enter in all approaches. We have seen in just the previous slide. Antiresorptives offer a very high level of protection. This is something clear. The data are there. They protect against osteoporotic fractures. But we also have anabolics, which are a novelty with indication in high risk and very high risk women. This is something which is, as I said, is not well established, but most of the clinicians and most consensuses are in that way. There are new data suggest that the first anabolic approach may offer more protection, but still not sufficiently settled. There are non-osteological variables that we have to bear in mind and which are very important. For example, adherence, because if we have the best of the drugs at hand, but people don't take it, probably we will have nothing. Also quality of life, adverse effects. And a rational sequence has been proposed, but as I was commenting, still we don't have sufficient evidence to say that this should be the way, but probably this may be one way. And that's all. Thank you.
Thank you, Antonio, for that fantastic lecture that we have already received some questions, and the one from Fred Naftali that I welcome him to our webinar, and I will read the question later on. Now we will move on, and before to move on to the next, I would like to remind to everybody that the 8-11 of May 2024, we will have the 21st World Congress of Gynecological Endocrinology in our magnificent scenario of Florence, and there's the beautiful birth of Venus. This is an age where osteoporosis is not present at this time. We have now to think about what will happen in elderly population. But I invite all of you to join us in Florence. And then now I would like to move to our second speech, which is the other side of the moon. The second speech will be given by Professor Martin Birkhauser, and it will be on that other topic that also looking to the aging, growing of the population, which is osteoporosis in elderly men, the neglected risk. Can we have also Professor Birkhauser in the screen? Yes. And Martin Birkhauser is Professor Emeritus at the University of Bern. It has been head of the Division of Gynecological Endocrinology and Reproductive Medicine in the same university until 31 December 2008. His actual special interests are menopause, osteoporosis, and hormonal contraception. In 1987, he had received the Schering Award for his research work in the field of polycystic ovary syndrome. He is the treasurer of the International Academy of Human Reproduction. He is the treasurer of the International Society of Gynecological Endocrinology and past president of the Swiss Societies of Menopause, of Reproductive Medicine, Contraception, and the Swiss Association Against Osteoporosis, and a former member of the board of the IMS. Martin is also honorary founding president of IMAS, honorary president of the Turkish Menopause Society, and honorary member of the International Menopause Society and of the Menopause Societies of Switzerland, Portugal, Romania, Hungary, and Chile. And is a fantastic friend of his friends. And I would like to thank him to give us that lecture because, you know, we are studying gynecological endocrinology, but we are also elderly men. Then it's very important that somebody take care of the osteoporosis in elderly men, the neglected Greece. Please, Martin, you have the microphone.
Thank you, Andrea, for this much too kind introduction. In fact, you said the other side of the moon. I would say the dark side of the moon, because we know much less than on the hot side of the moon, that is the women. I try to get the next slide. Okay. I have no financial relationships to disclose.
Okay.
In fact, why should we speak about male osteoporosis in this session? There are several reasons. One is that if we take EMAS, much of our friends are interested in male aging too. And then I think we have to know something about male osteoporosis, because we might be the first to suspect increased fracture risk in the male partner of our female patients, namely in sexual medicine and in fertility. We all know that males are not liking to go to see a doctor, so we might push them to do it. Osteoporosis is a silent disease in that it causes no symptoms until a fracture is sustained. In male, it's exactly the same. Therefore, it's often unrecognized, and even when recognized, it is often undertreated, even more in males than in females. In postmenopausal women, 7% have undetected osteoporosis, and 40% have undetected osteopenia. In men, I think it's worse. It is estimated that in many populations, 1 in 5 men over the age of 50 years will experience an osteoporotic fracture in their remaining lifetime, and they don't know it. As global populations age and expand, the number of fractures is expected to rise by 310% from 1990 to 2050. You know well this slide. Just to remember, we have bone strength composed by bone quality and bone mineral density. Bone quality is composed by architecture, turnover rate, damage accumulation, degree of mineralization, properties of the collagen and mineral matrix. That is exactly the same in both sexes. If we look closer at the pathogenesis, we have low peak bone mass in male and female. We have age-related bone loss in both. And in males, we have male hypogonadism. In females, you would see here postmenopausal osteoporosis. But male hypogonadism is much, much rarer. It's not natural in a way as menopause. Therefore, most male osteoporotic fractures are due to secondary osteoporosis. The consequence is low bone mass, etc. You know the slide well, and it ends with fracture introduced mostly by a fall combined with low BMD. You see here the definition by the World Health Organization. The World Health Organization defines osteoporosis in postmenopausal women as a BMD T-score in the spine, hip, or forearm of -2.5 or less. They don't speak about males. Then we have the definition of the IOF, and there, if we look at the lower part, IOF says, however, since the operational definition of osteoporosis was established in the 1990s, there has been a relative uncertainty regarding the disease in men. which has led to underdiagnosis of the condition and consequent undertreatment of this population. So I think IOF is more modern than the World Health Organization if you look at males. We know that all fractures are associated with morbidity. This study is coming from women, but it's exactly the same in male. You have a death rate within 1 year of 20%, and 80% are unable to carry out at least one independent activity of daily living. That is after hip fracture, and that is for women. We have suggestions and some data that the inability to have a normal activity of life is worse in male than in women after hip fracture. Quality of life, of course, decreasing after fracture. You see in black at the right side, you see the comparison of a group having 1 fracture versus 0 fracture. Quality of life is decreasing, but it's much, much more decreasing if you compare women having 3 fractures versus 1 fracture. There is no reason to suspect that in male that could be better. It is, of course, worse. If you look around in your clinics, many males survive only and can subsist only because their wives or daughters are helping them. The risk of a new fracture increases with the number of pre-existing fractures. Exactly the same for both sexes. If you have had already 2 fractures or more, your risk to have a new fracture is significantly, much more significantly higher. What about the costs? We always think that the most expensive disease is cancer. If you look at this slide, it's based on IOF data. You see that breast cancer is expensive, but heart disease is more expensive. You see the figure here. But the most expensive thing to have is a hip fracture. So we have all reasons to avoid fractures, and to do that, you have to avoid the first fracture first. The risk factors for osteoporosis are 4 in women and 2 in men. In men, we have 2 good points. We have a higher peak bone mass and a bigger bone structure at the beginning, and we have a slow decline in the concentration of 6 years normal bone turnover. That has several consequences. One is that the risk of fracture starts later than in women. Osteoporosis in men is, if you look at the percentages, about 22% of all affected individuals in the world. That means much more women are affected by osteoporosis than men. Around the world, 1 in 3 women and 1 in 5 men are at risk of an osteoporotic fracture. And we estimate that an osteoporotic fracture is estimated to occur every 3 seconds. That's a lot. If you go to the European Union, the data from 2015, the prevalence of osteoporosis in our region is for women over 50 years, 23%, for men, 7%. And the lifetime risk of osteoporotic fracture in men of 50 years of age is 13 to 25%, depending on the country and the statistics. But, and that is still today, as like it was in 2015, only a small minority of men presenting a high or very high fracture risk are treated. So men are much more often undertreated than women. What about the incidence of hip fractures? If you look at women age 50 years, you have 22.9 as the remaining lifetime probability. In men, it's 10.5. Forearm, it's 20.8. In men, 4.6. And if we take any of these fractures mentioned above, it's 46.4 in women aged 50 years. And the lifetime probability in men is 22.4. That means it's less than women, but still 1 in 5 men will have a fracture. Here you see the comparative incidence of major osteoporotic fractures in number of fractures per 100,000 inhabitants. To the left you have men, to the right you have the women. But the scale is not the same. Look at it, in men the scale goes up to 5,000, to women to 8,000. The type of the increase is similar, but men start later to raise. And it depends on the country. The lowest increase we see for men in the United Kingdom. I cannot tell you why. The highest in the US. If you go to women, the lowest incidence again is in Italy, and the highest is again in the US and in Caucasians. So why this difference between the two continents? I wasn't able to find any concrete indications. What is the different fracture risk in men and women? If you look at the hip fracture, the risk of hip fracture is greater in women than in men, but the gap lessens with increasing age. If you go to the double osteoporosis epidemiology study, the ratio of hip fractures incidence rates between men and women was 1.45 at the age of 69 years, up to 69 years. It was 1.15 at age 70 to 79 years and 1.19 at the age of 80 years or more. So the gap is decreasing significantly if age increases. What is the mortality rate in men and women? Men having a substantially higher risk of death following fracture than women has been established by all studies we know. The difference is thought to be attributable to excess comorbidity and infection rates. In a group of older adults, 6 years of age or more, inpatient mortality following a hip fracture was 10.2 in men compared with 4.7 in women, and 1 year mortality was 35.5 in men compared with 28 to 2 in women. And this elevated risk might persist for over 10 years. We have to proceed the same way to recognize and diagnose osteoporosis in both sexes. We have to take history and clinical examination first, still the most important item to do. Then we can pass to conventional radiology, to osteodensitometry, FRUX, and bone markers in secondary osteoporosis and other lab tests. Here you see a list of general risk factors for osteoporosis in men. If we look at lean body as a risk factor first, we have to suspect first alimentation, poor in calcium and nutrition. The athletic triad can come in, important lack of exercise. The opposite may come in too. We have intestinal diseases, we have abuse of nicotine, and we have lactose intolerance. If we take as criterion height loss, more than 3.5 centimeters, we have to look for prevalent bone fractures, chronic rheumatic diseases, diabetes mellitus or metabolic syndrome, chronic renal insufficiency, hypothyroidism, hypoparathyroidism, glucocorticoids or Cushing's disease, use of antiepileptics and other drugs, and organ transplantation as the main risk factors for these two groups. The clinical examination has to be targeted at classical signs of osteoporosis. These include sudden back pain as a serious sign, change of body height, deformities of the spine, other signs of vertebral contraction fractures. Particularly, we have to look at the curvature of the spine at the shoulders, the Widow's or widower's hump. Do we see indications for other fractures? Are there signs pointing to secondary osteoporosis malignancy? That is especially important in men. And we have to recognize increased risk of falls. So that is exactly the same in males as in females. But in males, of course, we have to add a much closer screening for secondary osteoporosis because it's more frequent in men than in women. About 40 to 60% of all fractures are caused in males by secondary osteoporosis. There we have low body mass index, alcoholism, smoke, sedentary lifestyle. We have hormonal factors, glucocorticoid excess of endogenous basis like Cushing's syndrome, hypogonadism, including men suppressed hormonally for prostate cancer, hypoparathyroidism, hypothyroidism, and the gastrointestinal disorders we have seen on a slide before. If you continue, we have the systemic illnesses like rheumatoid arthritis, multiple myeloma, quite frequent in males as underestimated factor osteoporosis or simulating osteoporosis. We have other malignancies. Then the drugs you see here and other factors, rare factors like chronic obstructive pulmonary disease, the post-transplant syndrome or neuromuscular disorders. Then we have to discuss the point of the intervention threshold. We know the role of BMD is mixed. It provides the definition of osteoporosis, but is still only one of many risk factors. Also, BMD is a reasonably specific marker. It is not very sensitive. That is, people with a low BMD are individually at the high risk of fracture, but the majority of fractures happen in the population with a BMD above the T-score threshold of -2.5. That is simply because these people are at a lower risk of fracture, but there are much more of men in this age group than in the age group having a higher risk. The T-score threshold for men is a problem because we don't have solid data, but overall the evidence supports the use of a common T-score threshold and the female NRS reference range for both men and women. That has been an agreement made by IOF mainly. We have guidelines from the US, the Endocrine Society guidelines from 2012. They say men with a BMD of 2.5 or more standard deviations below the mean value should be treated. They say that all those with BMD within the osteopenic range and the 20% 10-year risk of major osteoporotic fracture or 10% risk of hip fractures have been treated. We have a different view in Europe. The French SFR Rio group edited some recommendations. They are more or less identical to the UK and the Danish guidelines. And they recommend a 1, 2, 3 approach with an intervention threshold T-score of less than -1 for a man with a severe osteoporotic fracture and a T-score of less than -2 for a man with any fracture. And Rio recommends treatment for any man if the T-score is lower than -3. And that is specific for men. You cannot see similar recommendations for women. And Greer says in terms of treatment choices, bisphosphonates are widely advocated, with teriparatide recommended for men with multiple vertebral fractures and denosumab for men with prostate cancer. But as I said before, the evidence basis for all these recommendations is much weaker for men than for women. Let us come to FRAX. You know what it is. It is intended for use in primary care. It calculates fracture probability from easily obtainable clinical risk factors in both sexes. The output is the 10-year probability of a major fracture. And femoral neck BMD can be optionally inputted to enhance fracture risk prediction. FRAX is well established in women. But if you look at these factors, we have all reasons to use FRAX also in men, because in men too we have to establish the intervention threshold. We did that in Switzerland. There is no validation in Swiss men for FRAX, but we think it's adaptable for the use in males as it is recommended by the new evidence-based IOF guidelines. And we think the same interventional threshold should be used as in women. You see it on a slide on the lower part. You have in green the moderate low risk group. Then you have in dark red the very high risk group, and in between the high risk group. So what we see too from this slide, we use a threshold that increases with age, because otherwise we would have an overtreatment of the very aged males. Then, of course, we have to think of fall prevention. The role of exercise important. Antiona said it before for women. We know that we can reduce the risk of falls by 23%. That comes from a review about the role of exercise in both sexes. So that's important. We have to do it. And males are, as I know, more resistant to that than females usually. Then balanced diet and supplementation is important. Again, the same rules as in females. In general, 800 to 2,200 milligrams of calcium should be consumed via the diet. and supplements can be considered if daily intake is below 800 milligrams, and the same for vitamin D supplementation if you have a deficit in your alimentation. This is well established for both sexes too. What about testosterone replacement? There we have the T trials done by the National Institute of Aging in the United States, and these trials demonstrate a significant increase of 7% in lumbar spine trabecular volumetric BMD after 1 year of testosterone replacement. They demonstrate bone microarchitectural benefits after 2 years of testosterone replacement. But consistently robust benefits of testosterone replacement therapy have not been demonstrated, and we don't have the fracture data we'd like to have. So in a systematic review and meta-analysis of testosterone therapy, benefit was only observed in lumbar spine BMD and only in a hypogonadal population in testosterone-treated persons. So when and how should we use testosterone replacement? First thing is we have to measure serum-free or total testosterone levels, otherwise we cannot give the indication correctly. Then testosterone therapy might be indicated in case of symptomatic deficiency. That means if somebody is symptomatic from male hypogonadism. And we have to look at it in a holistic assessment of the patient across bone, cardiometabolic, and sexual function. And that ideally in conjunction with an expert for endocrinology, not only women's health. Furthermore, hypogonadal men with osteoporosis should usually be treated with an established anti-osteoporosis medication. So we should combine testosterone and anti-osteoporosis medication, regardless of whether testosterone therapy is instituted. And that in order to most effectively reduce fracture risk. You see, we don't have the hip data, no proof at all that testosterone is sufficient there. So the holistic assessment of the patient has been studied in the TRAVERSE study. It is a study where testosterone has been given versus placebo in hypogonadal men, and that demonstrated cardiovascular safety supplementation. Remember, there has been a long discussion if testosterone replacement could increase cardiovascular risk in males or not. Now we know it doesn't. Then, of course, we have to look at risedronate and other bisphosphonates in men. Here's a study with risedronate once a week. We have a good increase of BMD at the lumbar spine. At the trochanter, we have an increase too. Total fracture, the increase is present but less, and femoral neck, it is less. So increase is best at the lumbar spine in this study. But we don't have the fracture data. What about zoledronate? We have a very significant increase here, the placebo group with zoledronic acid over 2 years in the change from baseline for the lumbar spine. So zoledronate is efficient at the lumbar spine, but again, no fracture data. What about the denosumab? The same picture. Spine you have here. This line shows the people who had denosumab at the beginning and continued. These had first placebo and then changed to denosumab. Same for all sites cited here. Total hip from the beginning after placebo. Same for femoral neck, trochanter, and radius. So denosumab is efficient, but again, fracture data are still not here. Another study with denosumab in men with low bone mineral density, the slide before showed osteoporotic men. Again, excellent increase to the spine, less at the total hip, and the femoral neck and the trochanter. There you have a phase 3 RCT to evaluate the efficacy and safety of romosozumab in men with osteoporosis. Again, very good result at the lumbar spine, but still BMD, not fracture data. Less at the total hip and the femoral neck. So the picture is quite comparable to what we know in some female studies. Antonia has shown it before. What about teriparatide versus alendronate for treating glucocorticoid-induced osteoporosis in men? A special case, but interesting case. If you look at the lumbar spine and at the total hip, the result is significantly better for teriparatide than for alendronate. That is a very new analysis, has been published last week. It shows the improvements in BMD with anti-osteoporotic medication in men. It is a review. You have as STE marked here, the surrogate threshold effect for benefit for fracture, because you don't have the real fracture data, it has been calculated. What about the different medications we can use? We have here alendronate, risedronate, zoledronate. Zoledronate increases its amelioration of BMD to a value that is above this surrogate threshold levels, even for hip fractures. Then you have bendronate below, denosumab below, and here abaloparatide, again above the limit for hip fracture. And then we have here romosozumab. The difference between zoledronate and alendronate is not easily explainable. I think it's linked to adherence too, as it was mentioned before. So the best solutions to look at this slide, but calculated not based on real fracture data, the best data are for zoledronate and abaloparatide. That has been published in 2017 already. Treatment sequence matters. When possible, we suggest anabolic therapy first, followed by potent anti-resorptive therapy. So the same conclusion, in fact, for males as we have seen before for females. What is the recommended procedure in men? Comes from the Canadian recommendations published in last October. If you take the whole population initiating therapy, male population, you have bisphosphonates in the normal group, then initial treatment 40 to 6 years of bisphosphonates, and then you have the drug holiday as we are used for females too. If you have a severe recent vertebral fractures, we shouldn't go to this way of procedure, but we should start with anabolic therapy, teriparatide, romosozumab in men too. And then we should follow by anti-resorptive therapy after the anabolic therapy. And if you go to this part of the schema, you see if there is a contraindication on tolerance to bisphosphonates, we should change to denosumab following the Canadian guidelines. I think that is what we can say about males. Data are weak, but at least I think we're better off than 10 years ago. Thank you for your attention.
Oh, thank to you. Fantastic lecture that we have to learn a lot and to see how we can face. Now, dear friends, we have a lot of questions coming from the floor, and I would like to start. I will make one question to one and then to the other, but if each one of you want to add something to the response of the other, please come and go in, and it will be absolutely fantastic. Then, one question from Fred Naftolin to Antonio. He asked, he makes several questions, but this one is, you mentioned that, and he's asking, how is the rank ligand passed between the osteoclast and the osteoblast? Is this via exosome?
Thank you for the question, Fred. How are you? Yes, very nice question. Well, this is something which I think is unclear. What we know is that the intervention is not only between osteoblast and osteoclast, but also osteocytes. And what we know is that the real sensor of where to start promoting a bone mineral unit, which is the conjunction of osteoclast and osteoblast, is the osteocytes, because there is a network of canalicula that connect all osteocytes and detect where in bone there is an area which needs to be replaced. So the old bone is continuously replaced and the area detected by the osteocytes. Having said so, it seems that the osteoclasts are cells that they have been also considered as the wandering cells. They are much less in number than osteoblasts, and they are induced to differentiate in the local area in which the digestion of bone needs to be taken place. So once they are there, it seems that the connection between osteoblast and osteoclast occurs in some way. I cannot tell you if it is via exosomes or just a release of the cytokine, because we know, for example, that not only rank ligand but also osteoprotegerine, which is the decoy receptor of rank ligand, are detectable in blood. So they circulate, and they probably are released there in some way. They are taken by the network of small vessels and driven to the osteoclast. But the detail, if it is via exosome or not, I don't know. I don't really know.
Thank you very much, Antonio. And now a question to Martin. A question raised from the floor is, why should gynecology be aware of male osteoporosis?
Well, as I think many couples are coming to see only us in relation to sexual problems or to infertility. And if we don't investigate males, nobody will do it. So we have to know about it. The different question is if we should treat them. I think the usual gynecologist shouldn't treat a man for osteoporosis, but he has to send it to somebody able to do it.
Thank you. And then Tevfik Yoldemir for Antonio is asking which sequence is preferred, antiresorptive first, anabolic later, or the vice versa?
Well, hi Tafik, how are you? Thank you for the question. Yes, well, it makes sense because according to the data shift study, it seems that the best option is first anabolic followed by antiresorptive. But also in that study, the combination of both was quite good in terms, it was almost similar in results. And the good thing is that in many of our patients, what we will find is that they are being under antiresorptive, and they come for the potential use of an anabolic. So finally, many of the cases that we will find will be first antiresorptive, then the possibility of using an anabolic. So there are many questions around that which still need to be answered, but that's a good point.
Well, if I may add something, the problem is that in many countries, the reimbursement is not given automatically for the anabolic version. So you have to start for financial reasons from the wrong side, in my eyes, because it would be much more logic to build up first the bone and then protect him to lose again, protect the bone again, to lose it too quickly. But for that, we have to act on our healthcare systems.
Yes, you're right. And then one for you, Martin, is you have already spoken about that point, but if you can go a little bit on more on deep. And it's from an anonymous. Has testosterone therapy been studied for prevention of osteoporosis in men?
Well, I just mentioned it. We have some data, but not very solid data. And these data suggest that if we look at prevention, we can protect lumbar spine by testosterone, but we can badly protect the hip. So that is the reason why today the trend is to recommend testosterone supplementation for the symptoms of hypogonadal men, for the vertebral fracture prevention, but to add at the same time another component like bisphosphonates to protect the hip. So I have to combine it. That's the actual situation or the actual stand of knowledge we have. Problem is that the whole research has been slowed down by the Women's Health Initiative in a paradoxical way, because there the notion came in that substitution by estradiol in women and testosterone in male might worsen the cardiovascular risk. And that stopped a lot of investigation that has been planned in the United States. So you are behind of what we could know without women's health initiative in men too. Paradoxical, but it is like that.
Thank you, Martin. And then Antonio, Teten Young asks, how long can bisphosphonate or denosumab be given safely in this life plan?
Yes. Well, this is an area under debate, and the warning of the agencies, governmental agencies in the world, mainly FDA and the European medicine agencies, is that 5 years is the time in which bisphosphonates may be given safely. But at the same time, it's true that it has been the general finding that by using it for longer and up to 10 years, there is no problem, because what we found, I have presented, which is the contribution of atypical femoral fractures of osteonecrosis of the jaw, which is just very, very small. So one could use bisphosphonates for up to 10 years. This is a consensus. There is no established data that can prove these statements. And concerning denosumab, there are data, published data for 10 years, but the drug is in the market for longer. I'm sure that many patients are following denosumab for longer. So, well, as I was commenting, probably the most sensible position is to attend adherence, and once the adherence is correct, probably continue with a drug, and for a certain point, probably just change if there is just the moment of considering, for example, an anabolic, or change the antireceptive. But this is something which is still unclear.
Thank you very much. And then now, Martin, Sorin Hershkovici asks, a recent analysis of use of antiresorptive in men show a puzzling increase in fracture in men. This despite increases in bone mass density. I know that this was a meta-analysis, but the result is still puzzling. What do you believe about it?
Could you repeat the middle of the question? I didn't hear it acoustically.
Yes, it was in a recent analysis of use of antiresorptive in men show a puzzling increase in fractures. This despite the increase in bone mass density. I would like to have your comment about it.
Well, I know that some reviews are contradictory, and in fact, I cannot explain this increase of fractures in the review you have cited, because other reviews, like the one I showed at the end, the review from last year, didn't confirm it later. So it remains open what happened in this review for me.
Thank you. And then Fred, Antonio, for you, it is very interesting. He put two questions. We read the first one. Do the anabolic agents affect all bone? For example, do they close cranial foramina, causing cranial neuritis, such as facial nerve symptoms, or any other of this point?
Well, not as far as I know. But I think that the experience we have is not enough to conclude about that. Usually, all the antiresorptives stop a process that has been initiated, let's say, physiologically. It's not physiological, but when you have an increased bone turnover, the drug, what that will only do is to stop or to decrease it where it is started because of whichever reason. But with these other drugs in which you stimulate the osteoblast, might it be that this is followed by the increase of bone, for example, in areas in which it shouldn't? Well, I cannot answer that question, but it's obviously a point that may be raised.
Yes, I think we need also more data rising. You know, sometimes we are unexpected results that can happen for any drug, and then I think we need greater number of individuals treated. And another question for you, Martin.
May I add something, Andrea?
Yes, please.
I think, Fred, makes an analogy to osteoporosis, if I make a correct interpretation. But that is, in my eyes, a different situation than the treatment by anabolics, but we don't have the data.
Yeah, he makes also another question that I will read. This is for you, for both of you. While most, this is Fred Naftali, while most attention is directed at the long bone, what about the articular aspect of the bone joints? For example, what is the effect of bone protective treatment on the incidence of hip or knee replacement surgery? Do you know nothing about?
I have no idea, I must say, I must confess.
I can only mention that in orthopedics is quite well received the idea that when they have a fracture, they treat it with teriparatide because they suppose that the process of recovery will be shorter and better. But I think there is no data, solid data about that. That's my view.
There's another point we could mention here. We know that the situation at the vertebral disc is ameliorated by estrogens. That has been shown by several groups. But until today, we have no idea what happens if you give testosterone. That should be studied too.
And now I would like to I will read a comment which can correspond also to a comment that I also believe on it. This is from Peter Greenhouse. Gracias, Antonio. Anabolics and antiresorptives have no apparent benefits for joint pains, cartilage, ligaments, and more apparently for intervertebral disc protection for any other postmenopausal symptom. Then surely a better holistic long-term strategy will be simply to continue menopause hormone therapy lifelong?
Thank you, Peter. Very good point. Many thanks. Yes, that's the thing. Yes. In our cartoon, menopause hormone therapy only occupied 8-10 years, probably 12 years at most. But this is just what most of women take. But we go to the point of whether we might continue using menopause hormone therapy for longer, which is something which is open and probably for many women is the correct answer. Sure, I totally agree that menopause hormone therapy is the most holistic approach, not only to osteoporosis, but all the other problems around the moment of this period in the life of women. And certainly with a great advantage that you don't have the problem of frozen bone. It's something which is physiological, which is a good approach, and with other benefits. Yes.
If you come to men, it's the same.
Your comment too, yes.
So there has been a big discussion about the de novo initiation of prostata carcinoma in men using testosterone supplementation. That was a big fear 10 years ago. But today we know by several studies, in fact, not really long-term data, but sufficient, I think, that is not the case. So men being substituted by testosterone don't have an increased risk of prostate cancer as far as we know now. So we can continue in men too, probably.
And then Juan Enrique Blumel, that I welcome him, he asked, on some studies suggest that osteoporosis is another manifestation of aging. Therefore, shouldn't the target of anti-osteoporotic therapy be cellular senescence?
Shall I?
No, I think yes. We have, we are now growing up in an age which is until now very poorly studied. Over 80 or over 90 population coming from a long history before, how they have to be treated, how we have to face in this individual the correction of diseases who started long time before and they survived to that one. Then I think this is a fantastic chapter for the future and also probably for our generation. What do you believe on that?
Well, it's an interesting chapter, but we have to remind that in the 1970s, there has been a book, Easterns Forever. The end was not really good of it. So we have to be a little bit prudent, I think.
Thank you. And then for Antonio, this is also from Fred. Elderly people tend to polypharmacy. Can the participants comment on drug-drug interaction with the use of the newer agent?
Yes, that's another point, an important point, Fred. Yes, because as you said, elderly people used to have in the kitchen a long number of packets of different drugs that they take. And there is always the point of whether there will be any interaction between them, and particularly these new products, which I don't think they are sufficiently investigated yet to be sure that there will be no interaction. So it is a possibility. Yeah.
Mhm.
Thank you. We have also another a huge series of other questions. Another one interesting is that one still from Peter Greenhouse. The most useful osteoporosis prevention drug, part of estrogen, is basedoxifene, as it is the only non-progestogen which provided endometrial protection. So I find it particularly useful for postmenopausal women with PMDD plus or less endometriosis. In Europe, we prefer not to also use fixed dosage CE combination. Are you aware of any research using transdermal estrogen with basedoxifene? Any plan?
Well, Peter, yes, very good point. Yes, well, I had a couple of slides of basedoxifene, but I removed them finally because it was a little bit too long. Finally, basedoxifene, the advantage is the one you suggest in your question, is that it is a non-progestogenic compound with a very strong effect on endometrial proliferation. So that's the basis for DuaVive, which is the combination of basedoxifene with conjugated queen estrogens. It's true that we are not so familiar or so fond of CE in Europe. Transdermal with basedoxifene might be a good option, but I am not aware of any studies in relation with that. Actually, I should say that the idea of using SERMs transdermally has been in the market, for example, for tamoxifen. And I have always had in my mind that it was a very good option, for example, against deep venous thrombosis, because we know that for estrogens it's a good option, and probably it might be also for SERMs. And we might get rid of that inconvenience when using SERMs, for example, for osteoporosis. But as I say, I'm not aware of any study about that.
Then we have another question for Martin. The question is from Jose Alberto Hernandez Bueno. The effect of testosterone influence the risk of prostate cancer?
Well, as I mentioned before, that was the great fear of the 10s and early 20s. But the data we have today is that on the prostate, testosterone has no negative impact, except if you have already a cancer. So it doesn't create prostate cancers de novo. And therefore, the new studies are showing no increase of prostate cancer incidence if you give testosterone at the substitutional level, not as a pharmaceutical level. So I think that is not, and the same is true for hypertrophia too. The hypertrophy of prostate is not the risk if you give testosterone. There seems to be even the contrary. But we don't have long-term data, and we should see if the studies still going on are bringing more information about this fact.
Thank you. And then, Antonio, this is from Luis Burgos, a question. What is the role of testosterone levels in the bone health of women transitioning to the menopause? We see more and more young ovulatory women with osteopenia or osteoporosis with normal estradiol level. What is the role of the end? Do you believe any possible role?
Well, during the menopausal transition, there is the loss of bone initiates before menopause, actually. During the menopausal transition, even with good levels of estrogens, there are some losses of bone which are already detected by densitometers. So if it is something which is related with testosterone, I think is unlikely, because there is no an important change of testosterone during that period. So I think it's basically estrogen. That's the idea. I don't know if I received the question correctly, but that's the
Yes.
Mm.
And no, and then we have also another question is related to the osteoporosis women who have also cancer after cancer-related osteoporosis. You know, sometimes the metastasis process is in the bone and then this rise the osteoporotic lesions. Can you spend some words on the topic?
Is this an allusion to the positive effect of bisphosphonates, may I ask?
Yes, yes, on any of these parts, because you know it's something that in clinical practice we see that women that they cannot make hormone therapy because they have bone metastasis, and bone metastasis is something who can make going faster the process of osteoporosis at local level and risk of fracture. And then what it should be the management of these anti-resorptive and or anabolic treatments in these women, both of you.
I think what we can defend is to use in these cases bisphosphonates because you have good results, especially for zoledronate, that you can slow down the process of the metastasization of some cancers, not of all of them. At the same time, you treat osteoporosis. That's the only thing I remember.
Yeah. There is some data about that in the Horizon study with zoledronate, in which women randomized to zoledronate, they had some better survival. I don't know if it was survival or just a reduction in metastasis. I cannot tell you now. And there was a debate about the possibility that bisphosphonates might interfere with the metastatic process, not only by preserving bone mass, but also by directly having something to do with that. As far as I know, this has not been clarified, but some data suggested that it might be something in that regard.
And I think especially postulated for breast cancer metastasis, that it might be positive there.
Yeah.
Thank you, Martin. It's another question for you. Which treatment should be used in male primary osteoporosis?
I think the first thing is to do the substitution for all other negative aspects of hypogonadism. And then, as it has been shown in some studies, but for BMD only, we have to add bisphosphonates for bone protection at the hip especially.
Thank you. And then another question is calcium carbonate in diet useful for men osteoporosis?
I cannot tell you, I haven't seen it mentioned, specifically in men.
Yes, it was also another question rising for women also where they asked the importance of calcium supplementation. You know, we have recently the vitamin D assay is more common and also the evaluation of calcium or calciuria or circulating calcium concentration and detection of women who have lower doses of vitamin D and also some of lower doses of calcium is quite frequent. What is your suggestion, Antonio, for that?
Yeah. We reviewed this point, and there is actually a clinical guide of EMAS, which concentrated on that point. Yes, it seems that the needs of calcium are less than has been recommended by some societies. For example, the British Society now has moved to 700 milligrams. 700 milligrams till 1 gram, which is a little bit less than recommended, for example, by the International Osteoporosis Foundation, which is 1 gram, 1000 milligrams till 1,200. And obviously, the best calcium is the calcium in the diet, because the pharmacological calcium, the tolerance is not so good in some patients. For example, they produce abdominal pain and constipation and so on. Even more, there was a debate about whether the increases in calcium provided by the pharmacological calcium might have something to do with the risk of cardiovascular disease, with the deposition of calcium, for example, in the atheroma plaques. But that's something which finally was not substantiated, but it gave was the basis of important debate about the issue. So finally, calcium obviously is important. Calcium needs to be at least 700 milligrams a day, according to what has been suggested, as I said, by some societies. And the best calcium is calcium in the diet. Obviously, if the diet does not provide enough calcium, you have to supplement with some type of calcium, either carbonate or other salt of calcium. But the best one is in the diet. And concerning vitamin D, yeah, there is also that debate of whether vitamin D should be replaced when it is not provided by the diet, which is the case of most of the population in the world. The data about the levels of 25-hydroxyvitamin D below 30, that some societies have considered insufficient, is something which has been is the matter of debate. For example, there is some societies that consider 20 to 30 a more appropriate level of vitamin D, because otherwise you leave out of that level most of the population in the world. It's difficult to accept that something which is so prevalent might be something which is not, which is dangerous or incorrect. Or anyway, this is a debate.
Okay,
Well, if I may add for
yes.
side. If you look at the conclusion of the guidelines published last week by IRF and the Canadian guidelines, it is the same rule as everywhere. We don't have a concrete answer. If there are not sufficient data in males, we have to apply the rules valid for females until the opposite has been shown. That sounds a bit weak, but it's the only thing we can say. So I think that's valid for vitamin D and calcium as well as for hormones.
Thank you, dear friend. Now we are approaching at the end. And then I would like to ask each of you to make a comment. We started at the beginning with Antonio. We start now with Martin. Martin, you know, we are growing and growing up, and the general age of the world population is growing. We reach ages which were not expected at all. And then certainly the problem of fracture, the problem of fragility of our bone structure is becoming more and more apparent in elderly. Then looking into the elderly men, we are less than the elderly women, but looking to the elderly, old-aged men going in the population above 90, did you believe that we have to activate a program of prevention of fractures at that age, independently from the past history? And what kind of suggestion you would like to give if you should be a legislator able to modify the general rules?
Well, I think firmly that we have to do something, especially in men. Men are not known to be very preventively
Yes.
So we have to offer them, if we can afford it, some free tests at age steps like 50, 55, 60, etc. And that would include a clinical examination. And I think we should, at least at the age of 60, 65, offer a free DEXA measurement. And then we should push the treatment by, I call it now, substitution entre guillemets for DHEA2 in men too.
Yes.
And unfortunately, DHEA in some countries is still classed as illegal because it can be abused to increase muscle mass. And that should be stopped at the first thing to do. So it should allow to prescribe DHEA to elderly men too, as we do it in women in some countries. So I wouldn't go directly to testosterone, but I would go to preventive measures, preventive tests, support for good alimentation, vitamin D supplementation, and perhaps DHA before testosterone.
Thank you very much. As you know, as a DHA user, totally agree with you. And then Antonio, for you, another question. Also, And it's not only aging the world population and women too, but women in any case, they live even longer than men. We see the example in Europe, the example in Japan, and so on. What it should be your suggestion also? What to do in their strategy to face the growing of elderly population as preventive exam to try to reduce the wastage of the bad consequence of fractures?
Well, I think I might adhere to what Martin has commented. I agree totally with him. I think that to increase the awareness about which is the threat in terms of bone health may easily add to the awareness about all the other systems in the body, cardiovascular and so on. So the point is that when people arrive at 50 something, 60 something, is the moment in which most of the non-communicable diseases start the subclinical stages. So this is the moment to stop atherosclerosis, to stop osteoporosis, and to stop cognitive decline. And for that, the easiest way is probably to increase the awareness about lifestyle. This is something which is clear, but finally, not many people follow guidelines concerning physical activity or nutrition. Nutrition, I understand that in some areas of the world, probably to speak about good nutrition is a bad joke, because probably they don't even eat the most basic things. But physical activity, for example, and if possible, good nutrition, good supplementation of calcium when needed, or vitamin D, as we were commenting. This is very basic. And obviously, also in the health practitioners, I think is important that they check if there is problems in that regard. Today it was the bone, so the bone should be evaluated whenever the age is sufficient. 65 years, for example, is maintained or supported by many scientific societies, but also to attend those people who have risk factors, because those will need probably that assessment earlier than the general population. So the point is finally to be aware of the problem, to gain an impact at the level of health practitioners and the whole population about the attention to these non-communicable diseases, which is the big threat for both men and women, even if women live longer.
Thank you. Thank you. Thank you. Thank you, dear friends. Thanks to both of you. It's now clear also from that fantastic webinar that gynecological endocrinology provide a scenario where we can try to evaluate and to bring up all the endocrine factors who are responsible of the evolution of human life, not only for women, but also for men. And it will be fantastic to discuss later on with you in Florence also, or in our Congress also, this data. Then I would like to thank Martin and Antonio of being with us today. And it's my pleasure to announce another fantastic webinar, that on human sexuality, which will be the 22nd of May, always at 3 o'clock Central European Time, with Rossella Nappi and Peter Cedraui. I invite all of you to come to us. It will be another fantastic, stimulating webinar, just showing us gynecological endocrinology society activity. They are spreading in many, many other chapters of woman, but also men life, and sexuality is an important part of that. Then I thank all of you. I thank again Antonio and Martin for your beautiful presentation and for being with us. And I invite all the participants to join again at the next next ISGE webinar on women's sexuality. Thank you, Martin. Thank you, Antonio. Enjoy the
Florence.
Thank you. It was nice to
We
chat.
will see very soon. We will see very soon.